Hi, my name is Pia Tuominen, and today I'm here with Professor John Reid from the University of East London. You're the Professor of Clinical Psychology there, and I'm a former psychiatric patient, and we are here for our 5th episode together. I'm so excited to be here, and we are recording for our series, Challenging the Medical Model of Mental Health, a call for humane, evidence-based services that respect human rights. Such an important thing to talk about, and our topic for today is antipsychotics. And I have had experiences with these medications myself, but I thought of starting out with something my first encounter with antipsychotics was actually before my own personal experiences with the medications, and I thought of starting there and perhaps use that as a starting point. Before I got to university to study psychology, I was studying in a University of Applied Sciences for about a year. And as part of those studies, I was at a 4-week internship at kind of a day center for people who have had mental health difficulties. And I remember one occasion on that 4-week period, I went for a walk with someone who was coming there, this adult woman. And we went for a walk as part of the activities that we could do there. And I, as a student, was walking with this woman when suddenly she started to quite quietly to start to whisper and to speak to herself by herself something. And I was confused, like what is this? And I asked her, what are you doing? I can't hear what you're saying. Could you speak a bit louder? And she replied to me that I don't have to worry about that. That she's just chatting with the aliens that she had a connection to. We got back to the day center, and I reached out to the director of that center and mentioned to her that I'm worried about this woman. I'm worried that she doesn't take her medications. And that was my understanding at the time about antipsychotics. It's against psychosis. So if they are taking these medications, there won't be any symptoms. That's what they do, that they are specifically targeting the psychotic symptoms. And if they are taking the medications, there shouldn't be any symptoms. And I was thinking that maybe we could use this as a starting point and to perhaps talk a little bit about this idea, what antipsychotics are, what's the history of them, what other names they have been called, and perhaps there is some kind of names that could be better suited for them if we think what they do and how they actually work. What do you think? Is that a good starting point?
Yes, it is. Okay, so in terms of names, the two most common other names are neuroleptics, which is kind of Greek for seizing the nervous system, which is kind of what they do. And major tranquilizers it was the original term, not used quite so much now, but it's a very accurate descriptor of what they actually do. They are very effective tranquilizers. And I just want to start out by saying that the two things we always say at the beginning when we're talking about psychiatric drugs before we go any further, please do not make any changes to your medication if you're on it, or recommend to friends or relatives to make any changes on the basis of one podcast. Talk to your prescriber, do more reading, whatever, but don't make any changes just on the basis of listening to us today. And to acknowledge, because I don't know about Pia, but I will certainly be quite critical of the drugs in terms of their safety and efficacy. But I need to say also at the beginning that they definitely help some people, which is true of every psychiatric drug or even ECT. So some people do benefit from these drugs. I just wanted to say those two things. So let's go back to the names, a major tranquilizer. To understand why they're called major tranquilizers, we need to go back in time to look at the beginning of these drugs. It's a type of drug that was initially used for surgery to help slow the pulse rate and basically tranquilize people in preparation for surgery. It wasn't a replacement for complete general anesthesia, but it was a sort of precursor to general anesthesia. So they were tranquilizing people in preparation for surgery. And somebody had the idea that let's try these drugs on psychiatric hospitals, because there's a lot of very distressed people in there, and are running around causing havoc and distressing themselves and other people, and difficult to manage. So perhaps it would be useful to have a tranquilizing drug. They did have other drugs before. They had chloral hydrates, which was kind of used to put people to sleep for 2 or 3 days, which, looking back, probably wasn't such a bad idea because it didn't have any side effects. But that's a whole other story. They used to call it sleep therapy, actually. And they also had barbiturates, but they were beginning to realize just how very addictive barbiturates were. So they did start using these drugs. 1952 was the first time these were used. A very good year. Some good things came into the world in 1952, as well as antipsychotics. And then they were very effective. They were definitely calming people down, and wards became less chaotic and less dangerous, and less stressful for the staff and for other patients. And that somehow got eventually, well, quite quickly actually, misinterpreted as these drugs are curing the illness of schizophrenia, or treating the illness effectively, which of course is not true. But you can see how people thought that. These people were better. They were less distressed. They were less loud and talking out loud to their voices and getting distressed by the voices and acting on the paranoid delusions. They were slower. They were slowed down. So the next thing that happened was a fatal error, where they decided that if these drugs are treating schizophrenia, maybe we've discovered the cause of schizophrenia, because they started trying to understand what the drugs are doing to the brain. And there's a huge consensus, is not a disputed fact, that what the drugs do, they do many, many things. They affect many systems in the brain and the body. But one of the first things that was identified is that they block the dopamine system effectively, especially the D2 receptor. But so they then decided, well, if they block the dopamine system and these people are sort of getting better, the cause of schizophrenia must be overactive dopamine systems, which was well-intentioned. It was not very bright, because it's a bit like saying headaches are caused by the lack of aspirin in the body. It's very simplistic and silly, really. But that was the origin of the theory that still is talked about today, 70 years later, that there's a thing called schizophrenia caused by overactive dopamine systems, which is not true. And in fact, it's kind of the opposite, because what happens if you block the dopamine system, or anytime you do any artificial interference with the brain, or the body for that matter, the brain reacts and tries to compensate. So if you block the dopamine system, if you've got two synapses in the nervous system and which are communicating with one another, and you block that, what happens is, on one side of the synapse, the gap between the neurons, it starts pushing out more dopamine to try and get through. On the other side, so this is a bit technical, but it's kind of important. On the other side, the dopamine receptors are multiplying and getting bigger to try and suck up the little bit that's getting through. So you do end up with an overactive dopamine system, but it's caused by the drugs. And this has been 1972. I remember Professor Seidner at Massachusetts, I think he was head of, I can't remember exactly, head of neurology, but 1972 identified this. Didn't make any difference, so they carried on regardless, saying that the dopamine overactivity was causing the illness that the drugs are treating, whereas in fact the drugs are causing the overactive dopamine system, which is quite a bizarre thing to get your head around, that the drugs that are supposedly treating this illness are actually causing it. or causing the overactivity. So anyway, that's a bit of a little bit of history there. And yeah, so that goes back. That's why they were called major tranquilizers. So yeah,
Yeah.
there for now.
Yeah, this gets me thinking about this concept of dopamine supersensitivity psychosis. Is there something you could say about that?
Well, when people try and come off the drugs, there's that has some of the same withdrawal effects as other drugs. This is a real taboo topic. We have broken the taboo around antidepressants in the last 5 to 10 years, and just earlier this week, huge announcements in the United States from at government level around antidepressant withdrawal. But it's still a bit taboo to talk about the fact that all sorts of things happen when you come off antipsychotics. So you get the normal withdrawal effects, but you also can get psychosis as a result of the supersensitivity that has been created. Because if you suddenly withdraw, or even if slowly withdraw that blockade between the two synapses, you've got this rush of dopamine because the blockade isn't there anymore. So you've got a rush of feelings, a rush of thoughts, completely overwhelmed, and you kind of look crazy. In fact, in a way, you are crazy at that point. By crazy, I mean completely overwhelmed by your thoughts and feelings, because the dopamine is just pouring through at a massive rate if the blockade is, has been there long enough, and that overactivity has been created. And what's sad is that people are not told this.
Yeah.
So what happens is you go to, I don't know if this happened to you, Peter, I'm sure you'll have a lot to say about your own experiences, but you go to the doctor and you say, I want to come off. They say, no, you can't, because you need to be on there for a long time, because blah, blah, blah. And then you try and come off yourself. And because nobody's told you what to expect and how slowly you need to do it and how you need lots of support, you do have this rush of dopamine if you remove that blockade. And the doctor understandably says, see, I told you, the schizophrenia's come back, hasn't it? I told you not to come off them. And you go around this loop that people are endlessly trying to come off and ending up believing that they have got a permanent illness. And the evidence for that is every time they try to come off the medication, the illness seems to come back. Whereas in fact, that is a withdrawal effect of the drugs.
Yeah, I think it's one of the most harmful traps that there are in psychiatry, because in addition to this kind of a trap that you can get into, and when you try to get off the drugs or withdraw from them, you get the symptoms that can be interpreted as symptoms of your original illness coming back. And then in addition to that, you have likely you have a diagnosis that doesn't make you a very a trustworthy person in the eyes of a doctor. So it's very easy for them to think that you lack the insight, and you don't know what is going on, and you don't understand your situation. And I've talked with so many people who say that the effects of these drugs, I think desperate is a word to describe what they are telling me about their situation, when they say that they are so dulled. And that's my experience also with these drugs, in addition to, well, different kind of experiences. I was reading through my papers last night, because I haven't read them all the way through, all the notes, and I'm perhaps halfway through. I have a whole binder of them. It's very thick binder. It's very impressive to think that there's so much there, and I've been looked at through these disorder lenses, and it's kind of a disturbing experience to look at your past, the way you are described and the way your symptoms are described. And nowadays that I know a bit more about these drugs than I did back then, I can see some changes. There are changes that are made in my medication, and then there are changes in my symptoms. And usually when the medications are increased or new medications are tried in addition to the older ones, I get worse. And it's very weird to look at the situation. And those are not always seen in the papers. like this, they don't expressly say that, okay, we need to think about this medication like differently. And at one point I was even like I was questioning about if like there was many naps that I was taking during the day, and I was asking the nurse if the medications might be causing this, because like I'm sleeping all the time, and there wasn't any mentions of like what I was answered or anything like that. But that's something I had been wondering. The way I was described in the papers that I read was many times there were situations where the words that were used was something like I'm very expressionless, like I don't express myself very much. I talk in a monotone way. I'm quite slow. I don't find it any like it's not a surprise that I was slow, given the list of medications that I was on. There were even 2 antipsychotics at the same time, plus other medications. So I don't think it's a like a surprise for anyone. But that's how I was described in the like intake interview situation. So the like what bothers me is that we don't often recognize what is the effects of the drugs, what is the effects of the so-called underlying illness. And it's very easy to start mixing them and only look at the person through this kind of an illness lens, and not recognize that at least some of their symptoms might be caused by the amount of medications that they are on. Yeah, just
well, one of the 5 main symptoms of schizophrenia, so in the DSM, is as you all know, is something they call negative symptoms, and they are, you know, absence of feeling, absence of a social life, just absence of life, really, just being completely closed down. And those are the primary effects of the drugs. But they're reframed as, oh, these are the negative symptoms of the illness. Again, well intentioned, but very, what's the right word? Unhelpful, I think, in terms of trying to understand what's going on. And we've done surveys of, you know, hundreds of people on antipsychotics, and the top 5 adverse effects are all about tranquilization and sedation, basically lack of feelings, tiredness, exhaustion, lack of interest in the world. The word zombie comes up a lot when people are asked. I felt zombified or tranquilized or sedated. Couldn't get out of bed, and some of this can get interpreted as improvement, especially if you've been someone who's been very I don't know, whatever the word, manic or agitated, or and perhaps shouting or getting upsetting other people or being a bit aggressive or whatever. That can be seen as improvement if someone's doing less of that, like, you know, what happened in those early years in the 1950s. And to be honest, I can imagine myself being so agitated and upset that just, you know, please give me a drug that would just calm me down for a few days. You know, I'd rather it was chlorohydrate, which would just put me to sleep, because it doesn't have the side effects that we're gonna come on to. So I get that being tranquilized isn't always a bad idea. I think we could probably all imagine needing some help calming down, and when we're at our worst, when we're at our most upset. But that's really all they do. The only benefit of the drugs is that they are effective tranquilizers, but we have this illusion that they're treating a disease. It's like Joanna Moncrief, that the British psychiatrist, who has this, you know, the drug model and the disease model, 2 ways of thinking about the drugs. And the disease model says the drugs are correcting some sort of imbalance or whatever, which never turns out to be true. And the drug model, which is, let's look at the actual effects of the drugs. Forget whether they're treating an illness, because they're not. And then let's actually be honest about the benefits and the side effect of the drug, because all drugs, whether they're street drugs or prescription drugs, have some benefits and have some side effects. And maybe we do need to go through the other adverse. Yeah. Is this the right time to do that, or you?
Yeah.
Okay. So yes, the main problem is tranquilization, which can, as we said, be a benefit. But for decades, the worst adverse effect was something called tardive dyskinesia, which is a movement disorder which manifests in its worst form of uncontrollable shaking of the arms and legs. It starts off in the mouth, and the first test I remember as a nursing aide being asked, or always check with the patient, get them to open their mouth and see if their tongue is moving uncontrollably. That's the first sign of it. And it's can be quite a serious adverse effect. It occurs in about 30 to 60% of people on antipsychotics, depending on how long they've been on them. And the drug industry itself has acknowledged that for 75% of people who get it, it's irreversible. And another thing that a lot of people don't know is that it's a strange mechanism whereby the drugs actually mask the tardive dyskinesia very often until you come off the drugs, and then the tardive dyskinesia either reveals itself for the first time or the full extent of it becomes visible. And that went on for decades, sort of largely unacknowledged or downplayed or minimized. And it kind of led to the second generation. There's two generations of antipsychotics. They're called first generation, second generation, or typical and atypical. So the first generation of things like stelazine and thorazine, which were truly awful drugs. People talked about akathisia, which we should come back to. I'll leave that for now. So the second wave of drugs was largely marketed as not as necessary because they don't cause tardive dyskinesia. So suddenly, when we had this new wave of drugs in the 1990s, suddenly tardive dyskinesia was being talked about because it was the pharmaceutical industry's marketing tool for the next wave of antipsychotics. Right? These don't cause this thing that we've denied for 30 years. Suddenly, we can talk about it because we've got a new drug. Turns out they're minimally better at they do slightly less often cause tardive dyskinesia. But there's a whole range of other adverse effects. I mean, I could talk for the whole hour about them, but I'll try and just list them so people are aware of them. In a way, the most alarming one is the rarest. There's only about 1% of people get this. Is neuroleptic malignant syndrome, but it's important for people to know because its signs are very rapid increase in temperature and complete rigidity of the body. And if you get that and you don't get off the drug within 24 hours, you die. Now, people are much better now than they used to be at recognizing that and getting people to stop immediately. But there was a few years there when quite a lot of people were dying because nobody knew what was going on. So neuroleptic malignant syndrome is important to know about. There's effects on the cardiovascular system, which have been fairly well acknowledged. The interesting thing came out about 2012 was discovered they actually, if you're on them for a reasonable amount of time, 5-10 years, they actually reduce the brain volume, the volume of the brain, which is quite remarkable thing. You would think any drug that did that would be removed from the market pretty quickly, but no. So that's another effect. They have also been established. It's also been established that they reduce the lifespan. Now this is complicated because people with a diagnosis of schizophrenia, on average, die 20 years earlier than other people, which is an astonishing statistic. That's not all attributable to the drugs because there are other issues such as smoking, poor diet, some of the effects of poverty and nutrition. That sort of thing is definitely in there. And as an aside, I have to say that the amount of smoking in psychiatric hospitals, a lot of that is because it does counteract some of the adverse effects of the drugs, which is a whole nother interesting side issue. But but even in studies where you control for all of those other factors like smoking and poor diet, the length of time that you've been on on antipsychotics does correlate with the reduction in lifespan. And that's a polite way of putting that these drugs, if you're on them long enough, are slowly killing you. I mean, people don't like to say that, reduction in lifespan. It sounds a bit more neutral, but that's a serious problem. Then there's the metabolic effects, which are glucose intolerance and diabetes, which also can, that's part of the why they are life-threatening, or reduction in lifespan. And there's what some people say is not so important. This is for some of the drugs, because they're not all the same, of course. There's this massive weight gain, which you can say, well, weight gain, it's a small price to pay if it's keeping you sane and so on. But when you think that the primary time when people are put on these drugs is sort of 18 to 25 the first time, being massively overweight. I mean, it's important at any point in one's life. That combined with the reduction of sexual dysfunction. So you're suddenly massively overweight, your sexuality is either reduced or gone completely. These are hugely depressing things for young people, especially if they're not told that these are the side effects of the drugs. So now I think, so what's wrong with me? I don't feel anything sexually, but it's another thing that's wrong with me. Oh my God. And even if they do know it's the drugs, it's still difficult. So yeah, it's a long list of very worrying side effects, and it's adverse effects. I must stop using side effects because it minimizes them. Because you've got the positive effect and the adverse effect. You put all that together, and it's not a surprise that 50% of people, with or without the support of their doctor, usually without, will come off these drugs within 12 months of being put on them, because they just can't tolerate the sort of feeling you were talking about and all these other adverse effects. Even if they feel they're helping them a bit with their problems, with the psychosis or whatever, the side effects are, for many people, just completely intolerable. And they end up, they go for support to come off them, they can't get it, so they often stop taking it cold turkey or whatever. But we've sort of talked about that. But I'm saying the adverse effects are so bad that just so many people just, there's some adverse effects with other drugs you can put up with. It's a trade-off, but for many people, that especially what you talked about at the beginning, that feeling of, call it what you like, exhaustion, closed down, just having no life, no energy. People just don't want to live like that.
Yeah. Oh, there's so many things I'd like to say. But one of the things that comes to my mind is a person who told me that she can basically tell by her profile pictures on social media when she's been on antipsychotics and when she's not. Because she, like, after being in hospital, she every time quit those medications, and she said it's clearly visible in her profile pictures. Like there's so much more expression, and she was wondering, like, doesn't the psychiatrist see how different I am without these medications versus when I'm on them? Because they don't even realize when I'm on them and when I'm not, if I don't tell them that I've quit those medications. And like, she was just wondering about the how good their observation skills really are, because that's one of the things that I was wondering as I was reading the papers, my papers yesterday, because there was some mentions about like my weight gain. I was using Zyprexa for a few years, and there was mentions that my enormous weight gain might be related to the use of Zyprexa, and like afterwards, like just before that medication was switched to another antipsychotics, because I was like tired of that weight gain, and I had a 15-minute walk to a grocery store, and I always made sure that I ate before I went there, because I didn't want to buy like everything, like chocolate and potato chips and ice cream and cereals and everything, because it's just the the hunger was endless. Like it was practically endless. And even then, when I made sure that I ate a whole meal before going to store, like a grocery store, for the 15-minute walk, I was hungry when I get to the store. And I bought ice cream, I bought chocolate, I bought candies, I bought potato chips. There was like no sense of like make sensible choices. It wasn't an option. It was like everything that is like candy or something buttery or something sugary or something salty. That's what I was eating, and it was absolutely awful. And when the medication was switched to another antipsychotics, my weight started to drop. Like I didn't do anything. I didn't like walk more or anything like that. Just the hunger stopped, the enormous hunger. So I was just wondering, like, how is that supposed to help me? Because in addition to that, you mentioned that some people think that yeah, like a weight gain is a small price to pay if it keeps you functioning, but it didn't even keep me functioning. I was barely functioning. I couldn't concentrate. I wasn't doing anything like particular. I couldn't read. There was not much to do. The weight gain was absolutely awful. And I've been wondering, like, how is this drug supposed to help me? Now that I was reading the papers, and there was certainly a couple of mentions that my weight gain might be related to that. Yeah, might be. It was very fun to read, you know, very fun, like, yeah, not really, you know, to read the Suprexa papers by Jim Cotstein.
Yeah.
And to read about, like, this was known, all this was known, but hidden. And it's one of those things that like this idea of connection, connecting with other people. Like if you have some sort of a bad side effect or adverse effect like tardive dyskinesia, and you're trying to connect, like you can't really connect with other people because it may seem very weird for others that how you're, like, what you're doing, and this uncontrollable shaking and everything. But the same is true, I think, in these kind of situations when people gain a lot of weight. It affects your self-esteem. The barely functioning, it affects your ability to connect with other people, and like all these issues that there's preventing you from getting like a good relationships, preventing you from getting the like the helpful thing about being social and having friends and being connected and talking with people, because there's so much like difficult things around you. All this weight gain, all this barely functioning, all this like feeling dull, not showing expressions very clearly, not being like a sociable person, basically, because you're so tired all the time. So like I'm just thinking to myself, like, what are we doing? What are we doing? Like, I do understand that at least like for a while or at some situations, they might be helpful. But the way we are using this, and as I was reading the papers last night, I was thinking that I had a feeling that I barely escaped. I barely escaped the system.
Mm.
And I don't know where I would be if I hadn't. It's a tough thing to think about.
Well, some people do end up on the drugs for 10, 20, 30 years.
Yeah.
Yeah. And I think it's really important you're talking about the interpersonal consequences, because we're not very good at talking about the actual biological effects, but I mean, there is some acknowledgement of that. It's often minimized, but at least it's acknowledged. But the sort of things you're talking about, how it makes it virtually impossible to get better, because getting better involves, as you say, having friends and support and having a life. And it makes that, you know, for some people just can't get out of bed, never mind all the other things that you're talking about, the low self-esteem, which makes you not feeling confident about being with other people, and then the actual effects of, you know, the movement disorders and yeah. So it's actually, I would say, you've said it already, Peter, it's stopping people from getting better.
Yeah.
But what the psychiatrist sees is a lack of some of the more extreme agitation, or yeah, they see a calmer person, where the person is, what's the experience has been tranquilized and turned into a bit of a zombie with no energy and no feelings and no life, the psychiatrist will say, well, yes, that's good. They're calmer now. I've helped them. And you could say both are true, I suppose. But yeah, there's a whole nother area here, isn't there? That I don't know if we should move on to it now, because these are the drugs that more than any other drugs can be used with coercion. Should we move on to that aspect? Because every country, of course, has its mental health legislation where you can compulsorily treat people if they're deemed to be a risk to others or themselves and have a mental illness, etc., etc. But the drugs that are involved in that are almost antipsychotics. You tend not to be given antidepressants or anti-anxiety drugs compulsorily. I mean, you can be, but it's almost always antipsychotics. So now you start moving into the issues around informed consent and human rights, because the surveys we've done, at least, we asked people, were you told about any of these adverse effects? And the answer, about 1 to 2% were told. So about 5% were told something, and 1 or 2% were told about specific things, withdrawal effects or whatever. So most people are told nothing, and that's perhaps understandable from the psychiatrist's point of view, because I think they're worried that if they told people, let's assume they know all the adverse effects. That's not always true, but let's assume the psychiatrist has read the research, knows the adverse effects, and has got to decide what to tell someone like yourself in a situation you're in. Do I tell Pia all these things? If I tell her all those things, she's probably not going to take it. And I think these are going to save her life or stop her doing all. So whether it's a conscious process or not, it's a kind of an understandable process, because I think a lot of people, if they were fully informed about the adverse effects of these drugs, they wouldn't take them. So that's not an excuse, that's a reason. It's unethical, because medical and psychologists, we're all bound by the ethical principle of informed consent, but people are just not told. So that's issue number one. And then there's the issue of giving it to people after they said, no, I do not want this. And there is no other way to describe that than a human rights issue. And the World Health Organization, the United Nations, are very clear that this is unethical, a breach of human rights to forcibly treat people. You can't do it in any other branch of medicine. I mean, there's a few exceptions. If someone's unconscious, you don't need permission to give them a defibrillator or whatever to get their heart started. But by and large, you can't treat people with things, even cancer drugs. If someone doesn't want cancer drugs, even if you know that's going to save their life, you can't force them. But this group of people, you can. They seem to have a different bar for human rights. And one of the ways, and I think this is particularly insidious, because so many people stop taking the drugs because of the adverse effects. As you know, I don't know if this ever happened to you, but they have, for the last 20 years or so, having an injectable form of the drug, long-acting injections, so that the drug is in you. You can't stop it because it's in you for either a month or however long that, and that it can be forcibly emitted. You can be held down forcibly and injected with the substance, so that you can't stop it. I can't think of a more blatant example of human rights abuse than forcibly injecting a substance into people that can cause so many adverse effects. So there's a whole set of issues there. I'll stop. Sorry. But
This is one of those things in like even within psychiatry that gets me to think about loneliness the most, like the feeling of absolute loneliness. Because as a patient, if you're trying to tell your loved ones, your family members, that you don't want to take these drugs, so often they say that the doctor is saying that this is a like progressive disorder, you have to take them, this is psychosis is neurotoxic, you have to keep using these medications. The doctor is, if you're not if you don't want the medications, they can force you. And then there are other people you might want to tell that I don't want these medications. And then there are all these, as we talked about, like these issues with feeling connected with other people, because perhaps you're like you're too tired to take care of yourself. You're all the weight gain issues, all the dullness and everything. It's very difficult to connect to other people and to really be heard with your worries about like, what is this doing? I don't like what this medication is doing. And all that can be framed through this lens of like lack of insight. You don't understand your situation. This is for your own good. That's one of the like absolute horror situations that I think people don't realize that you can find yourself in. Like alone in that situation and realizing that this is not doing good for you. And then you're trapped in that situation.
Yes, because we all want to trust the doctors, don't we? Our relatives want to trust the doctors. And when we're upset and maybe doing things that are a bit unusual or whatever, we're going to listen to the doctor rather than our loved one, which is a shame. I mean, the dilemma that you just described is that, yes, very often a refusal to take the medication is seen as this lack of insight, which is seen as a symptom of the illness. So it's like if you disagree with your psychiatrist about what the treatment, that is proof to the psychiatrist that you have this illness and therefore you must have the medication. So that's a real powerful double bind. You can't talk your way out of that, because the more you insist, no, I really don't want. Well, yes, that's your lack of insight. That's because you're ill. If you weren't ill, you would understand you needed to. It's and again, it's well intentioned. It's unhelpful, and you could even argue stupid, to not listen to you. I mean, this is a larger problem, isn't it? It's the not listening. So how do you help when someone's in distress? How do you help them without having a therapeutic relationship with them? And how do you have a therapeutic relationship with them if you're breaching their human rights and not even listening to them when they say, I don't want this, doctor, I really, really, the only response is then, okay, what else can we try? Or at least can we talk about this, and can I try and persuade you? If you don't want it, I'll respect that, but I'd like to try and persuade you, because I think there's some, rather than just, no, you have to have it, and if you say no, we're going to inject it into you. And then there's no trust after that. I mean, how can they, how do they expect people to be helped by them if they take this coercive? It must be, I've often thought it must be quite unpleasant for them as well, to have people so angry with them and distrustful of them, and not appreciating their efforts to help, because they mean well. It must be very unsatisfying. I mean, psychiatrists have I mean, this is an aside, I don't know if it's the right time to, they have the second highest suicide rate of any profession after dentists. And I often wonder, is that because they're trained to do these things to people that make people so cross with them? Yeah, that's a kind of an aside, but I mean, there's two sides to this story, and I think everybody ends up miserable, quite honestly. I can't. If somebody feels satisfied after having compulsorily injected something not quite right with that person. Do you know what I'm trying to say? I'm trying to see it from their point of view, but they believe they're helping. They wouldn't do it if they didn't believe they're helping. They don't think they're making it worse, but very often they are. I also think they're often treating their own anxiety, Pia, about, because again, I think we said this before in other sessions we've done, other discussions, that if somebody does go off and do something terrible, like kill themselves or harm somebody else, they are the ones that get the blame, not the nurse, not the psychologist, not the whatever, the physiotherapist, or it's the psychiatrist who gets the blame. So very strong expectation on them to do whatever they think they can to stop these bad things from happening. The problem is there's no evidence that these drugs actually do reduce violence or suicide. And the other, sorry, go ahead. Yeah, okay.
Yeah, and then when we compare the bad things that can happen if someone doesn't medicate, how about the bad things that can happen when someone medicates, like for example with force or without force, but anyway, this dullness and feeling like you're not alive, and all these other issues with the medications. We also have to take into account those. Although I do understand the perhaps anxiety that can be related to the role of the psychiatrist. But
yeah, when I worked as a psychologist, I had suicidal patients. You just worry about them all weekend, and are they going to, are they going to show up to the session on Monday, or am I going to get that phone call? That says that, it's really a hard thing to carry. And if you've been taught that doing X will reduce the chance of that, then you do it.
yeah,
But it's the other component to this is the compulsory treatment orders. I don't know what they're called where you are. Do you have the same thing where you can?
yeah.
You're allowed out of it was presented as this progressive thing. You're allowed out of the hospital on the condition that if you don't take your medication, we can bring you back in. That's real 1984 type sort of control of people's lives. You can live your life as long as you take the medication, and we're going to monitor that. And if you don't take it, we're going to pull you back into hospital. There's been 3 well-designed trials of community treatment orders, only 3, and all 3 found they make no difference whatsoever to hospitalization rates or symptoms or anything. They don't work, and yet they carry on. Most countries carry on using them. We had a review here of our Mental Health Act a few years back, and they actually put in the report, these studies show it doesn't work, but we're going to carry on anyway. Actually, and I think that genuinely is treating the doctor's anxiety. If the doctors know that and keep doing it, that's just strange, I think.
Yeah. Just to clarify a bit about the situation in Finland, I'm not sure if we have technically the exactly the same thing, but I've heard people say that that they are being like coerced into this kind of if you're not doing this voluntarily, we are going to force you. So they, even with like outpatient, like people who aren't in hospital, there's these situations where people are told that like if you're not doing this willingly, that we can force you and force you to come to hospital and so on. So it's a really tricky situation, because that's not a true option. If those are your options, it's not a true option. So like a situation where you can choose. But something that came to my mind, when I was studying to become a solution-focused brief therapist, in one of our training days, we talked about psychosis. And one of the students mentioned that if someone is psychotic, in that situation, of course, that person has to be medicated, because we won't get a connection to them otherwise. And me being me, I asked quite frankly, for whose sake are we medicating then? In those situations, if that is our reasoning for giving the medication, that we don't feel connection, we don't feel connected, we don't get a connection to that person if they are not medicated, like who are we medicating for? Is that truly the best interest of that person who is very like distressed or whatever is going on, and we don't feel that we can reach them well enough if they are not medicated, or if they are behaving in some weird ways or talking about some weird things? If that makes us more calm, who are we medicating for? Like truly, and how can we do that to another human being? Like so that my situation is better, I have to medicate you so that you like behave differently.
Yes, I can see the argument that if people who are very agitated are calmed down a bit, they might be able to connect better. I can see that argument. But very often that argument is used to justify the medication, and people are then not provided with any psychotherapy anyway. Occasionally, I guess it can be true that someone can be calmed down, and then because of that, able to benefit from other types of support. But the other issue here is where is the training for mental health professionals to be able to communicate with people when they are in an extreme state? Where is the training for how do you be with someone who does have a different reality from you at a certain point in time, who does think, I don't know, that every red car on the street is out to get them, or is hearing voices that you can't hear? Where's the training that should be what we're teaching people how to do, how to be with people in extreme state. But no, the answer is to change their state chemically so that then we can talk with them. But I don't think most people have those skills, and they're quite. That's all I ever wanted to do as a clinical psychologist. When I started out, that's all I wanted to do, is work with people who did have psychosis, as it's called, because I just found that fascinating, and I like to think I was quite good at that. But it's also very hard and draining to connect with people who are very frightened, in a really quite frightened or very angry state, which can get turned on you. It's it's very satisfying work, but very draining. And I just don't see those skills very much in the mental health workforce. It's not. It's better than it was, to be fair. When I was training, I was many years ago now. I was taught, don't talk to people who are psychotic. They don't. I mean, you have a cup of tea, but don't ask them anything about what's going on in there. It'll make them worse, John. So we were told as clinical psychologists, don't talk to these people. So that's, nowadays, of course, we do teach our clinical psychology students around CBT for psychosis and various other psychotherapeutic techniques, and the importance of the therapeutic relationship. That's the most important thing to understand, is that especially with people who are frightened of the world, which is a very simple way to understand a lot of psychosis, because bad things have happened to them, the main thing you have to be able to do is establish a relationship with them. That is the task, because in a way, if you've done that, you've almost accomplished what you need to set out to make it safe for that person to have a relationship with another human being, which is sometimes the first time they have, because of the awful things that have happened to them. But we're off on another topic now, so I'm just going to close the window because my dog's in the garden barking. If you can hear him, but right.
So our time today is coming to the end.
Already? Okay.
Just before I ask you for the last words, I'd like to say that fortunately our next topic will be a psychosis. So we have plenty of time to talk more about like different ways to approach, or different kinds of ways to approach psychosis. So that is a good thing, and I'm excited for that
That'll
session.
be a bit more positive, won't it?
Yes, certainly. Yes. And I'd like to say our listeners and viewers that if you like these episodes, if you like this series, please share this with your friends and let them know also that we are doing this kind of series. And now I'd like to ask you, John, if you have any last words for today.
Yes, and really to repeat what we said at the beginning, don't make any changes to your medication as a result of this. If you do decide at some point in the future, after talking to or trying to talk, because it's not always easy, but trying to talk to the prescriber, if you do decide that you want to come off these drugs, it'll be very important to do it very slowly and carefully, with as much support as you can muster, do it at your own pace. Same as what we said about antidepressants. The slower the better, but it's different for each person. So yeah, that's important. Throwing them away can be, as we've talked about, can be not a good idea at all. And to also acknowledge that if you are listening to this and you think the drugs are helping you, then they're helping you, and that's great. Different things work for different people. So I think what we're saying is we need to increase the awareness of the adverse effects so people can make better choices. And if people know all these adverse effects and still want to be on that, I think that's their right. Just to say all of that, but also how much I've enjoyed talking with you, as always.
Thank you. I enjoyed this time together with you also. Even though these are difficult topics, it's good to be here to talk this through with you, and hopefully people find these helpful. And will share these with with their friends and get more people to hear these different takes and the informed consent, especially because I think that is the most important part for everyone to hear.
Yeah. And next time to be able to talk about what the alternatives are. It's all very well as saying this is not so good, but we need to be able to talk about and there's lots of alternatives. So I'm looking forward to that session.
Yeah, me too. But now, bye bye.
Okay, bye bye, Pierre. Bye everybody.